Well, I'm always appreciative of getting to talk to Dr. Usmani, and I hope you're doing well, Doctor.
Um,
I wanted to follow up on one of the questions and comments that was made about Ninlaro, which is also called Ixazomib for new listeners out there. And it's the newly approved oral proteasome inhibitor, unlike its cousins that are infused, the carfilzomib or the Velcade. And I'm wondering, Doctor, if you are having patients the use of Ninlaro off-label, such as in induction treatment, first-line treatment, or more likely even in maintenance, where it becomes a much more convenient oral therapy versus the other two that I mentioned. And if in maintenance, are you prescribing it to be used alone or with Revlimid or dexamethasone or both? Can you talk about that?
Sure, Jack. We have, what I can tell you is 2016 has been a challenging year for many patients from the insurance perspective. I've had a lot of challenges trying to get, so that was my first inclination. Now, patients who are receiving bortezomib as either single agent maintenance because they have specific disease features or convenience because they didn't want to be on an oral agent every day. When we try to get Ixazomib, we are getting pushback from the insurance companies. They would only approve it if it's utilized with lenalidomide and for patients with one prior line of treatment. I have been able to get away with 2 patients, but for most of my patients, I've had refusals, and I have been unable to get this for the upfront setting at all. I think it would be a really cool idea, especially for our transplant ineligible patients who may have high-risk disease, in whom we're considering a proteasome inhibitor IMiD induction, to have that oral option. But we are getting, I'm personally getting a lot of pushback from insurance companies, despite the fact that we've tried.
So at this point, if I wanted Ninlaro on maintenance, I might be advised to see whatever clinical trial might exist for that, correct?
That is correct, sir.
And same question along the lines of Daratumumab. Do you think there's going to be benefit in using Daratumumab, Darzalex also called, in induction therapy, and in what combination? And with Dara, when you're using it, how are you finding patients managing the long infusion times or dealing with side effects? So kind of a 2-part question.
Sure. Daratumumab is being evaluated in upfront clinical trials in the first relapse as well as the upfront setting. In the upfront setting, there are 2 large randomized phase 3 trials that have fully accrued. One has fully accrued and the other is going to be fully accrued in another 4 or 5 months. In the upfront setting, there's a trial that is comparing the combination of Daratumumab with RD or Lendex and comparing that with Lendex on its own. And this trial is for transplant ineligible folks. A very similar design trial was conducted or is being conducted in the first relapse setting, and that trial had finished accrual about a year and a half ago. It's similarly a Daratumumab bortezomib dex versus bortezomib dex large phase 3 is being run in transplant ineligible newly diagnosed folks as well as first relapse patients. In fact, you may have heard about the press release today that the combination of the trial in the first relapse setting, combining Daratumumab with bortezomib and dexamethasone, came back with a positive result at the first interim analysis, and these data will be presented at the ASCO meeting in June 2016, which is very exciting, which means that the three-drug combination for our first-line setting patients was able to give a positive result very, very early. So it was, the difference was so stark that they don't need a second interim analysis. So it's really exciting. The company is very mum about the results, and we're probably going to hear about this at ASCO in a couple of months. So for the transplant ineligible folks, Dara is moving forward as part of as an independent mechanism of action that can be partnered with proteasome inhibitors. For the transplant eligible folks, it's being combined with a three-drug combination. I can share, some of my anecdotal experience with this combination in earlier lines of treatment. The depth of response is fairly robust, and as we know, that the deeper the response, the better the progression-free and survival outcomes, with therapies in myeloma. One of the major challenges with Daratumumab has been the infusion time, especially the first infusion. My site has been involved with Dara development for over 3 years. So it's, we know that we need, if patients are coming in for Daratumumab, it's better to start the day early for their first dose. So generally patients are coming in between 8 and 9 a.m. and getting started on therapy so that they can finish on time within 6 or 7 hours if they don't have a reaction. But if they do have a reaction, it can make for a longer day, up to 8.5, 9 hours. And there have been some instances that other investigators have reported that they because they started late, they had to admit patients to finish the infusion. The way that the company is trying to mitigate that is by developing a subcutaneous infusion of Daratumumab, and that phase 1 is accruing actively, and I have several patients on that study. The infusion time is about 30 minutes, and it's given sub-Q. The other thing that the company is developing is a more concentrated formulation of Daratumumab so that the infusion can be given much quicker. The side effects that we're generally facing are low-grade side effects. So patients presenting, when they're 1 hour into their infusion, they're developing some itching, scratchy throat, runny nose, and giving Benadryl and a small dose of steroids can, mitigate those side effects. For the patients who develop grade 3 reactions where they're developing some shortness of breath or muscle spasms, breathing treatments and high doses of steroids or antihistamines may have to be given. But once that reaction is over and the patients are re-challenged with Daratumumab, we don't see the side effect or the infusion reaction coming back. We think the reaction happens because the Daratumumab, CD38 is expressed on many different cell types, including the respiratory epithelium. So, there may be, an inflammatory reaction in the respiratory epithelium the first time the patients are getting in, and that's why we get those side effects.
Are the infusion times being decreased at all in subsequent infusions?
Yes. So from the second infusion onward, the infusion time can be reduced to between 3 to 4 hours.
Thanks so much. It's always a pleasure talking with you.
Thank you, Jack.
Yeah, thanks, Jack. Cindy, are you online?
I'm online. Can you hear me?
Okay, Cindy, your questions?
Okay. The first question I have, Doc, is kind of a follow-up to what you were talking with Gary about the importance of seeing a myeloma specialist, and also the disparities that, there's some areas of the country where it's not really easy to get to that myeloma specialist, not like where I live in the Northeast. Has the idea of telemedicine for myeloma specialists ever been discussed? Having virtual consultations like through a Skype once your lab results or blood results are sent to a specialist? What do you think about something like that?
I think that is an awesome idea, and it would be, a great idea to develop regional myeloma tumor boards like that. We are developing a mechanism here in the Carolinas of making that available. That mechanism available. It hasn't been rolled out yet, but the idea is, you have a monthly teleconference where the community doctors can discuss their challenging or difficult cases with the myeloma experts at my program. I think we need to have more engagement like this with the outside communities, which are 3 or 4 hours away from the nearest myeloma center. I think that's a fantastic idea, Cindy.
Great. I would like to be able to use some of this technology that we have to service the areas of the country that are kind of underserved. My other question is that I saw something about a new formulation of Melphalan has been recently approved. Can you talk a little bit about what that means and how is it different from the Melphalan that we all received during our stem cell transplant?
Sure. So, the way that Melphalan has been formulated previously, was for the longest time, I'm trying to recall the name of the new formulation, but nevertheless, the new formulation is a Captisol-enabled Melphalan.
Evomela.
There you go. Thank you, Evomela. And so Evomela is Captisol-enabled. Captisol is the same chemical compound that is utilized to stabilize carfilzomib, for example. And the advantage of using Captisol is to stabilize Melphalan and so that it doesn't degrade, and its PK or pharmacokinetics and pharmacodynamics are more stable. So the stability of the compound is extremely important. The other concern that we've had with the older formulation of Melphalan, is the potential for erratic toxicities, not simply the GI toxicities, but the concern about cardiovascular side effects or toxicities. So, having this Captisol enabled Melphalan helps mitigate some of those concerns. I think Dr. Harry out of Medical College of Wisconsin was the myeloma investigator who evaluated this new formulation for patients who are getting their stem cell transplant in the upfront setting as well as in the relapse setting, and found it to be as efficacious as standard Melphalan, with some benefits from the side effect and tolerability perspective as well. So it doesn't, it's not a major scientific advance, but certainly makes the Melphalan delivery a little more stable.
Okay, that sounds good. We've talked a lot about...
one other thing on that same line is I understand that because it's reformulated, this Melphalan, that you can give higher doses, and as a result, these higher doses will allow you to have a better outcome. Is that?
Yes. So, with the old formulation, the degradation, Melphalan degrades fairly quickly once it's mixed in the bag. With the Captisol-enabled Melphalan, that degradation issue, just like you said, will be overcome.
So that the Melphalan will be available in your body for a longer period of time. Is that what that means?
No, that means that the dose that you calculated to give to your patient is the dose that will be delivered.
Oh, okay. That's what degradation is. Okay, that sounds good.
Yeah. So the chemotherapy is in the bag and it's breaking down even before the patient gets the dose.
Oh, I did not realize that. Okay, so the way that it's encapsulated, or whatever that word is, it won't break down as fast, so when it gets delivered to your body, it's the dose that the doctor intended you to get.
In other words,
correct.
It kills your immune system better.
Okay.
And it can be technically given over a longer infusion, and you can infuse it slower than you would the regular propylene glycol containing Melphalan.
Okay. I think I got it. I'll have to read a little bit more, but I think I got it. The other questions I had, we might have some new listeners here on the phone tonight, and we've been talking a lot about the high-risk myeloma. Can you just give us a brief understanding of what is high-risk multiple myeloma, about what percentage of people who are diagnosed with myeloma have these high-risk features, and what do you think are the most exciting clinical trials for this group of people?
All right. That is a very loaded question, and you've asked, I'll try to answer it efficiently.
Okay, I'm sorry.
No, not a problem. So, in a very simplistic way, high-risk myeloma is any myeloma that will result in a patient passing away within 2 years of diagnosis. Now, that is a very simplistic way of putting this, but I do want to highlight that within high-risk myeloma there are features that are patient-specific, and then there are features which are disease-specific that can cause you to have high-risk disease. You can have even easy-to-treat disease, but if you're not getting the right treatments because you have other comorbidities that will prevent you from getting treatments, that myeloma may be high risk for that particular patient, despite the fact that they don't have, nasty chromosome features or, poor risk by gene expression profiling. But high-risk myeloma by disease biology is a very, very broad group. There are many different ways in which we identify high risk. There are certain clinical features. There are patients who present with circulating myeloma cells in their bloodstream, which we call plasma cell leukemia. We know that kind of myeloma tends to be very aggressive. Then there are patients who have extramedullary disease, which means myeloma outside of the bone marrow. So patients presenting with myeloma collections in the liver or skin, even in the CNS or brain. Those patients tend to not do well with standard treatments and have a high risk of relapse. Then there are features on FISH testing, which is a special test done on the bone marrow aspirate sample, where we're looking for specific chromosome abnormalities. The translocations of chromosomes, such as chromosome translocation 1416 or 1420, are considered high risk. translocation 414 is considered intermediate to high risk. There are certain abnormalities on fish like deletion of 17p, which is considered high risk. So these fish abnormalities, what they really mean is the patient's chances of disease relapsing after frontline therapy is high because the myeloma cells tend to be a little more aggressive and perhaps more resilient to the available treatments. There are other second-generation tests like gene expression profiling, which can identify patients at high risk of relapse within their first 2 years of diagnosis. All in all, about 20% or 2 out of 10 myeloma patients will have high-risk disease, and it will be, one of these features that will be able to identify high-risk disease. It is a very heterogeneous population of patients, and which, again, I said this earlier on the show that myeloma is not one disease; it's many different diseases. So the high-risk definition or the high-risk category also includes these different features.